Hi, I'm Aaron. Welcome to Renew Psychology Review, where we're going to be talking about the latest in mental health research and how to apply that to your life. Today's episode is particularly direct to that point. It's about the span of mental health to mental illness and commonalities along that span between different mental disorders. This show should be useful for people who do have a diagnosed mental disorder along a fairly wide spectrum of severity, as well as those of you watching who don't have any particular mental health struggles that you'd necessarily pick out, but you just want to live the best life you can. So let's get into it. So this episode really came largely out of this book that I've been reading, Persuasion and Healing by Jerome and Julia Frank. It's a book that I had heard was pretty significant to the history of mental health treatment, that talks about connections between the process of psychotherapy and other forms of healing that people get out of traditional sources, shamans, religious healing, cultural institutions, things that we wouldn't necessarily be used to in mainstream American life, but that turn out to have some commonalities with therapy in terms of the persuasive elements. Now, I may do a whole episode in detail about this book, but the particular piece of it that I wanted to take out of it and do this piece about was that the book pointed out that a lot of research, and this book is not brand new. I am going to talk about some really recent research here, but this book has been through a few editions and was most recently copyrighted in 1991. So we've had close to 30 years of research since this that still supports it. But the point that I want to get at here is that this book talks about there really being one common factor in psychopathology, in basically mental illness struggles. So what does that mean for there to be one factor in psychopathology? In psychology research, psychology has kind of struggled throughout its existence since the 19th century for recognition as a proper science. For those of us who have been brought up with fields like physics or chemistry standing in as the paradigm of this is how science is done, psychology really doesn't look like that. So in physics, force equals mass times acceleration. Force will always equal mass times acceleration. That is all it ever is. There's never any question about that. So that has a sort of certainty and mathematical elegance to it that I think appeals to a lot of people who do physics, and also kind of gives a field like physics an appeal for the rest of us to look to as an example of how science is done. But I think a lot of us looking to psychology for explanations, for better ideas about how to live our lives, what's going on when we're dealing with other people, how do we handle our relationships, things like that. There aren't really equations. It doesn't have that nature. Dealing with another person is not an equation. You know, maybe you could come up with some way to model it, but I think that to most of us, that kind of has the sense of like sucking a little bit of the life out of it, that a little bit of what makes the experience what it is the wholeness of it. The fact that it wouldn't be the same thing if you took parts out of it or tried to simulate it or anything like that. It's about human beings. It's about living creatures interacting with each other emotionally in terms of our thinking minds, all these different dimensions to it that come together. So when we think about categories of mental health and mental illness or mental disease or disorders, defining those has always been a tricky business. There have always been issues at the boundaries, and especially where these disorders, illnesses overlap. Much less, I mean, a lot of us, the same kind of resistance that I was just talking about to the idea of breaking human interaction down to an equation, I think there's the same kind of lack of an appeal to having like some kind of rigorous definition for mental health. Like, I don't want to have somebody tell me how to be healthy. Like, isn't it okay for me to just live my life? And let me just come out and say, in advance of anything else I'm going to say here, like, Yes, it is. This is going to be about one way of approaching this subject, and if it's helpful, use it. It really shouldn't have to box anybody in, though. With this, any specific ideas about how to approach these topics, they are absolutely not substitutes for actually having a real conversation and exchange about what's going well for you, what's a challenge. Having that conversation in a way where you get the sense somebody else gets your subjectivity, you're being heard as a whole person. So with that being the better approach, to be heard in that whole way, here's one possible way you could use to communicate to other people about this, or use to think about it yourself within your own space. When we break down mental disorders and look for these boundaries, a more recent statistically driven approach to this has been factor analysis. So factor analysis is a family of statistical methods that can be used. For example, if you had respondents to all kinds of different surveys, or if you had a large population of people who had been put through some of the diagnostic tests for the DSM, so Screen for Mental Disorders, you can aggregate that data together. When you aggregate that data together, that gives you the opportunity to look for correlations. What things go with what? What groups together with what? So when we get those correlations and those groupings, we can get a factor structure out of that, which is a hierarchical view of how many factors at a given level of granularity do you need in order to explain most of the variability in the data set. Now that's a very abstract idea, but we can make it concrete here. Other camera I was going to use for this is beeping at me. Okay, so to make that idea of a factor structure concrete, so let's think about the disorders we have in the DSM. If you are diagnosable for a personality disorder, obsessive compulsive disorder, ADHD, a mood disorder, any of these categories, these are treated as distinct entities. You can have more than one if you qualify for the criteria of more than one. The issue with treating these as scientific categories in the same sense as we would with in physics, like force and mass being different things, the psychological categories, they overlap quite a bit. For example, it's pretty likely that a person with ADHD would be more susceptible to depression and anxiety than somebody who does not have the diagnosis of ADHD. So that right there poses a problem for us of how do we distinguish which disorder is actually representative, or where to slice those boundaries. So various researchers have applied factor analyses to these problems, and the factor analysis, or multiple that was described in Persuasion and Healing, identified that actually the strongest explanatory power happens at the level of treating it as if there is one single factor of psychopathology. So one factor of health or illness that explains the bulk of the variability in whether somebody has any particular finer-grained mental disorder or not. So that's very different than I think the impression that we get of this from news articles where the finer-grained categories are used. So if a new drug is being tested for depression, then depression is usually the specific thing that they're testing it for. And sometimes in those studies, they might even actually screen out other people. So they want to control for a drug being tested just against people who have depression, not depression and ADHD, not depression and PTSD. So, so we might not get drugs tested against other people who might have similar issues who don't quite fit the description of depression, for example, or some other mental disorder, when really the nature of this thing is it's kind of a person is struggling or they're not struggling so much. So oftentimes when a factor analysis like this is done, there's a little bit of a leap or a little bit of hypothesizing to take to the next step of what do we call that factor. If we have one factor of psychopathology or one factor of mental health, what would we call that factor? And so this book, as well as some other resources that I looked at, had a few possible names for it. We could call it ego strength, which sounds a little Freudian. It might not be to the most modern tastes, but it describes the idea of kind of being able to handle stress and keep going and maintain a stable sense of self. So ego strength is one way to look at it. The term that was used in persuasion healing was actually demoralization. So the idea here, the authors of Persuasion and Healing were talking about connections between acts of persuasion, rhetoric, or religious exhortations, and how that can kind of resemble psychotherapy. Where was I going with that? So the element of persuasion, well, if you're doing psychotherapy, what would you be persuading somebody out of? You would be persuading them that they don't have to be so demoralized. And so these authors, Jerome and Julia Frank, they make a strong case over the course of this book that that does seem to be how psychotherapy works in large part, based on, for example, when people get into therapy, there's often very rapid improvement in symptoms right at the start of the treatment. So if you go to therapy and you happen to meet a therapist that you get along with, you have a sense that they can work with you on your goals, all those things I just mentioned, those are strong predictors of treatment success. So if you meet somebody like that, then you're going to feel encouraged. You're going to feel like, I took that step. I got here. I've found somebody that can work with me. And so if you're experiencing an element of demoralization, that's an underlying factor of the mental health struggles that you're dealing with, and you take that to therapy and get that support with it, then that therapy could very easily become very quickly curative for that demoralization. So what would we want to do with that concretely in our lives? This is another one of those things where I'm not just stating the question rhetorically. I want you to take a second and think about it. And think about it after this video here. But I also have a few ideas of my own. So, for example, heater's going off. I'm going to shut it over here. So, for example, I think one option could just be, if you have the option to go to therapy, set yourself a low barrier for going in there. Say, just if I feel like I'm struggling at all, this doesn't have to be the last option. I'm going to go to somebody for help. Or it doesn't have to be therapy either. If you're a religious person and you have a clergy person to go to, or if you have certain connections, a mentor at work, something like that, close family member, go to that person early and often. Bring up your struggles so that you can get some support from somebody else, somebody who can see your situation clearly and say to you, I don't think you have to be demoralized about this. I think you have strengths that you don't know about and you can keep going with this. You're doing better than you think. That makes a big difference. So that's one option. Maybe if you have tougher struggles, the kinds of things where you have been in therapy for it, it might be good to set yourself a really concrete threshold for getting help. Say, if I've been struggling with something for a week or 2 weeks or a couple months, I think probably my intuitive sense is for a lot of us, probably somewhere in the range of about 3 weeks to 3 months. If you've been struggling with something for that long, it's probably really worth getting some extra input on it. I don't know about you, but for me at that point, if I was dealing with the same problem over that span, maybe this would make my problem sound easy, but that's enough of a span for me where I would start to feel it dragging on me a bit, I think. Most types of problems that would happen over that span. So, you could just set yourself a rule. If I think back about a problem and I notice that it's been that long, then I want to think in advance and have concrete next steps when it gets to that point. I'm going to talk to this person or seek some therapy, pick up a book, do some exercises, something like that, to get myself back on track and to remind myself that I can get back on track. So those would be a couple of approaches to this idea of demoralization. There are different levels of the factor structure. And I think those can be useful to know about for having something that's a little bit more specific to your experience, something that tells you a little bit more about how you approach things. So the couple models that I've heard about, usually the next level down from the one overarching demoralization, ego strength type of factor, next level down from that has 3. And those 3 would either be internalizing, externalizing, and thought disorder, or I've also heard it broken down into... Man, we are having some video problems this time around. I apologize about that. Let me get myself back stationary here. Okay, I think we're good. Right, so factor structure. You could have internalizing, externalizing, and thought disorder as roughly independent, and I'll explain more about what those mean. You could also have an overlapping set of 3 characterized as internalizing, externalizing, and disrupted sense of self and other. Okay, so going through those, I'll just talk through them as the 4, even though thought disorder, disrupted view of self and other, those tend to be sort of exclusive categories in different analyses. Internalizing and externalizing, I talked a little bit about this too in my video on Nancy McWilliams and alternative models of personality. So internalizing describes a generalized tendency to turn things inward, to become depressed or anxious, to ruminate, to sort of lose energy in the face of struggles, this type of thing. So that's one factor that you can have contributing to an overall sense of demoralization or I'm struggling. Externalizing is somewhat the opposite of that, but it has its own features to it. So externalizing is a combination of I get angry, I express that anger outwards. In extreme instances, maybe I'd yell at people or get violent. So externalizing tends to be really strong in, let's say, populations in the justice system, people who have been to prison, especially for violent crimes. That's kind of definitional. That's a little circular there, but just as an example. Can also take the form of projecting or trying to manipulate people. So trying to put what's going on with you out there into the world and make it affect the circumstances around you. So treating those as independent factors, you can actually you can have features of internalizing and externalizing. They're somewhat independent. So mathematically, statistically, if you're answering a survey, you would tend to answer more of one than the other. People tend to be more internalizing or more externalizing, but you can also be less of both or more of both. So does that make sense? How that contributes to an overarching factor of general psychopathology. We have these roughly independent factors at the next level down, but they're not totally independent. They do sort of contribute to this next level higher factor where I can be more of both externalizing and internalizing. I can be less of both internalizing and externalizing. Asking that question as if people can answer, but hopefully if you're listening to this, please leave a comment. Let me know how I'm doing here breaking this down. So the other two factors, so thought disorder would be characteristic of delusions, hallucinations, features of schizophrenia, schizotypal personality disorder, maybe to some extent paranoid personality disorder, or just much more extreme presentations of personality disorders in general. So having odd thoughts that are hard to connect together, as well as hard to connect to the way that most other people would see a situation. So that kind of, in some analyses, the third factor is thought disorder. It probably depends on some matter of which studies have been included, as well as sort of a certain amount of intuition of once this third factor emerged, what is the study author choosing to label it? Because it's a mathematical entity made up of these are the questions that a person would answer yes to on a survey, or features of their personality that would be identified. Those factors make it up mathematically, statistically, but it actually needs a human being to identify a label for it and say, I think what we're measuring here, this is thought disorder. So there's some overlap between that idea of thought disorder and disrupted boundary between self and others. So probably the most familiar example of this would be if you've done any research of your own into borderline personality disorder, or if you have it and you're familiar, or probably a better way to put that is you experience features of borderline personality disorder, or if you have somebody in your life who does. So borderline people or the borderline experience is characterized by having a hard time maintaining a stable view of who am I? Am I basically a good person? Am I basically a bad person? Having a hard time integrating those poles. So not seeing myself as a person that's both good and bad at the same time, but either completely one or completely the other, and switching back and forth kind of erratically, very in a way that would make it hard for you, the person experiencing it, or for people around you to hang on to the experience and say, wait a minute, didn't this, like, aren't we missing something here? Doesn't this hold together with, weren't you just feeling better, or weren't you just feeling worse not that long ago? So borderline people struggle with that, integrating their experiences in themselves in the same way. And the same thing happens in a borderline experience with the experience of other people. I tend to experience other people as all good or all bad. And I have a hard time integrating that so that I can see people in a nuanced way with a lot of dimensions to them. So those descriptions of thought disorder with hallucinations and delusions versus a disrupted sense of self and other, they sound like they're talking about different things, but those two experiences do tend to go together. So for a person who is experiencing the psychotic phase of schizophrenia, they are having hallucinations and delusions, that also tends to go with having a hard time, in extreme cases, even having a sense of yourself as being made of one piece, not being kind of broken apart and scattered to the winds, unable to pick yourself up and create a whole consistent experience out of this. So extreme instances of thought disorder can actually involve extreme manifestations of having a disrupted sense of self. The same thing potentially with the sense of the other person. So we have this underlying factor structure where underneath the level of how demoralized am I or how well do I feel, there are these aspects of internalizing, externalizing, and thought disorder or disrupted boundary between self and other. If one or the other or multiple of those dimensions kind of describe your experience, especially when you're under stress, those descriptions might give you a little bit more to look out for. Because kind of characteristically, this stuff, especially for those of us who struggle with it, can sneak up on us. It can be hard to notice while you're in the moment that, that I'm engaging and internalizing. Or it can be hard to remember back to times when I wasn't doing that. Or the same thing, I mean, maybe the experience is a little bit different with externalizing. If you're really angry, then that feels justified, right? In a way, it almost feels good. It feels like I'm going to go out there and I'm going to get what I want. I'm not going to let the world get in my way. And so even if there are aspects of that approach that are adaptive, and there have to be, or none of us would be this way, it can still be a healthy thing to keep that in mind, to accept that I'm feeling this and I have reasons for feeling this, but just to kind of take a pause and say, I'm noticing myself getting into this. I want to think for a minute about this. Let me just think back and make sure I've got a clear picture of what was it recently, or maybe not that recently, maybe in the past couple days, week, something like that, that kind of started getting me down this path. That could be helpful so that you're acting from a clear place, and so that if you are actually feeling any anger, you're feeling, or anything else that would go into an internalizing, externalizing other type of experience, you put yourself in the driver's seat to ask the question, am I feeling an appropriate level of this, and am I also channeling it in a productive way? Is this way that I'm acting on this feeling that I'm having actually going to get me what I really want in this situation? So those are a couple things to think about. This all kind of connects back to actually another more recent sense of this idea of the higher order factor of psychopathology that I just read about more recently. So this has actually been, research has been done on this over about the past 6 years, since let's say like 2014-ish, under the label of P factor. That's letter P. So that's in analogy to, in the study of intelligence, there's this idea of a G factor, a general factor of intelligence. Not gangster, that's a different G factor. But G factor of intelligence is sort of a generalization of the idea of IQ. So P factor, similarly, is a unidimensional. I can have more or less of it, but it covers a linear scale like that, more or less psychopathology. So that more recent research on the P factor characterization of the factor structure of psychopathology, there's an idea there, a hypothesis that was put forth by Charles Carver and a co-author, that maybe the underlying process that contributes to that is whether a person is inclined to act impulsively on feelings of emotion in the moment or not. So if Carver and his collaborators are right about that, that would actually kind of go along with some recent popular new styles of psychotherapy. For example, there's a style of therapy called mentalization-based therapy. Mentalization is the process of thinking about thinking. That's all it is. It's just a word to describe that. So when I'm mentalizing, I'm thinking about my own thought process, or I'm thinking about another person's thought process. So mentalization-based therapy, that has been put out there largely as something targeted at severe personality disorders, especially antisocial and narcissistic personality disorder, which have never been totally untreatable, but they're notoriously hard to treat. So if a person going to therapy with one of those disorders or something else is at least willing to engage in the therapy enough to take that process of mentalization and practice it a little bit and run with it, that might actually help with that. Now, what Carver and maybe some of these other P-factor researchers are saying is that might not just be with those personality disorders. That might be that actually something a lot like mentalizing, a lot like the process of thinking about thinking, is really something that we would all benefit from. So I think on that note, I'm going to wind this down, and maybe what I'll do is post some links in the comments to some ideas about how to gain better awareness of emotions, how to regulate them in the moment, and some mentalizing exercises as well. Those are all things that people can find in therapy, but you don't have to have a diagnosed mental disorder. You don't have to be in therapy necessarily, I don't think, to make those things useful for yourself. So hopefully this has been a useful talk. I'm looking forward to hearing some thoughts if anybody wants to comment. And yeah, so many directions that I could go with this from here. Mentalization-based therapy could be its own, well, I should probably learn more about that before I do an episode on it, seeing as, just a reminder here, this is not a substitute for clinical treatment, and I am not a trained or licensed mental health clinician. These are my own perspectives on this that I've gained from reading as well as from doing my own work on myself. So I hope it's helpful, but don't make it out to be something that it's not. Please, if you need it, get the help you need. If you message me, I'd be happy to try and help you sort out some next directions for yourself that would get you moving towards somebody qualified. So anyway, with those caveats, lots of different directions that I could go with this discussion. I have so the reason I remember that Charles, or excuse me, what was his name? Carver. The reason I remembered Carver was I have another book by him actually back on my shelf here about hierarchical organization of goals. That would connect back to things that I've presented on before about approach and avoidance goals, things that came up in the McWilliams episode. So I'm really looking forward to filling out this channel and having some of these concepts tie together. I hope you are too, and thanks for taking the time to watch and listen. I'll see you next time.